So it's really a pleasure to welcome my colleagues to the session 6, healthcare system usage of telehealth. And what we're looking to do is, for my colleagues, is to talk about the current expanded role of telehealth across healthcare systems in the wake of the coronavirus pandemic. Dr. McVeigh, are you online?
I am. Can you hear me, Ron?
Yeah, loud and clear. Thanks so much, Fran, for taking time to dial in. Kevin, you there? Okay, I don't hear Kevin. Colonel Hipp, Sean, you online?
Yes, I'm online. Can you hear me?
Yeah, okay, Sean, loud and clear. Good commo check. And Dr. Rich Bakalar, Rich, you online?
Yes, I am. I'm on audio and video. Yep.
Okay, fantastic. And I see Dr. Joe Wood there as well. So, Joe, please join in as well on this session. What I'd like to do is just tee it up to Dr. McVeigh, Dr. Hipp, and Dr. Bakalar. If starting with Fran, then going to Sean, then Rich, if you could just comment on what was telemedicine like before and now in the COVID pandemic? What are some of the big observations you've seen in terms of different use cases, and then we'll dig into some other questions. So starting, Fran, with you, and then over to Sean and Rich.
Thanks, Ron. Just for some statistics, pre-COVID, across the military health system, which is all services, Army, Air Force, and Navy, we're about 13% of all encounters being virtual health, telehealth, we use the words simultaneously. And peak COVID around April timeframe, we saw it go up to about 50%. Now, recently, we're down to about 30%. And why is that? That's a combination of reasons in my mind. One is we're opening up more face-to-face appointments. And furthermore, in the DoD, we have yet to acquire a clinical healthcare platform. So we're using workarounds on these administrative video platforms, which are not necessarily conducive to delivering care for the patients or providers, and connectivity being some issues. So the heavy hitters, of course, are mental health and primary care following up behind them, and then specialty care. So we're seeing a slight drop off, but we need to compare it to where we started. We started at 13% pre-COVID. We're at 30% now, and I think that's tremendous. I'm confident, and the DoD is in the process of acquiring a clinical healthcare platform. Once we acquire that, providers will have something that they can count on, patients will be happy with. So I would anticipate that 30% would go up to probably closer to 40 to 50% once that is deployed. Those are my comments, Ron.
If I may come off mute here. I appreciate that, Fran. Thanks. And you know what I thought we'd do is stay with the DoD, with Colonel Hipp following up your comments, Fran, and then reach out to Kevin and Rich from a industry, healthcare perspective, a civilian healthcare system. So Sean, in terms of following up, how has telemedicine changed for you down at the San Antonio Military Medical Center now that the pandemic is in play? Over.
Well, thank you for having me on this panel. It's been a whirlwind, truly. We've been trying to honestly convince providers and staff to start doing telemedicine for decades now. And this really created a sense of urgency in order to transition to telemedicine platforms. But our issue is that the policies and the platform weren't in place at the beginning of this. So right in the middle of it, we developed and moved policies into place in order to make this more streamlined and make providers become more comfortable with what they were doing. And then we create a lot of education in order to try and use some of the administrative platforms that we had in order to connect appropriately to providers and patients out there. So it really rocketed us forward. But we need to continue to leverage this and keep this sense of urgency in order to move this forward, get the right platform for the military to really connect from operational to garrison and support the transition of that service member to the VA as we move forward. So we can have a seamless product working together, one EHR. So I think we have a lot in place right now to move that forward, but we still have a ways to go on the military side. Over.
Okay, Sean. No, I appreciate that. Yeah, that's been a challenge, as you know, with those of us here on this call having been in telemedicine for quite a few years now. And it's ironic that even though the pandemic has sort of accelerated use, especially in the civilian sectors here at the University of Pittsburgh, it's gone up considerably. We clearly appreciate the need to sustain this after the pandemic. What I'd like to do is get Kevin Orr's perspective. I see Kevin online from Covenant Health, and then get Rich Bakalar's thoughts from an industry perspective. But Kevin, with Covenant Health, what's changed since the pandemic came into our lives in the March timeframe? Over.
Well, first, as Sean Hipp said, thank you for inviting me to the panel, and it's just great to see all of you again. You know, we've been doing this for a number of years, and it's unfortunate that a pandemic creates this opportunity, but it also highlights all the good work that's been done over the past, years and decades. In my case, I arrived here on the 19th of March in Knoxville, Tennessee, sorry. And I was pulled in immediately as a result of the pandemic, obviously. So really literally hit the ground running. And I was pleased to find out that they had a program in place already. They had invested heavily in telehealth. The position I filled as director here had been envisioned. And so I'd say not so much that the planning changed, but the execution of that planning was greatly accelerated. And we did a few things ad hoc. I can elaborate on those later. But for example, we recognized very quickly that tablets might be very hard to come by. So we quickly put in an order for tablet-based capability, and we wound up getting like 50 of them, so that we could deploy those in emergency areas and COVID cohort areas and ICUs, and just to allow for communication and virtual health access there. So I'll stop there, but it was gratifying to come into a place that was already planning for telehealth, and it was a little bit disorienting being the new guy here one day, and it's like, okay, let's get this moving. So.
Yeah, no, Kevin, I appreciate that. Were you doing telemedicine consults at Covenant Health before the pandemic?
They were, yes. We had several specialties that were involved in telehealth already, as Fran pointed out, behavioral health being one that's kind of an obvious user of that, as well as neurology and nephrology and some of the other specialty care. And then, of course, as this has expanded, we've seen interest from many other places. One interesting aspect was that we had a couple of things that ceased to exist as a result of the pandemic, one being groups for virtual behavioral health. So people could no longer gather in a room and have groups for therapy. So they came to us, and we very quickly put them back in business via Zoom and some other technologies that were both on hand in those tablets I mentioned that we'd acquired. So another one was wheelchair assessments for rehab. People that were already immunocompromised didn't want to come into a clinical environment. And so we enabled third parties to go into their homes and allow those wheelchair assessments and fittings and tune-ups to occur, so that those individuals with that need could still be seen. So they came to us for that, and we were able to respond quickly, kind of outside of the existing plan.
Yeah, no, I appreciate that group therapy increased usage with technology because of the pandemic. So that's a great example of what's changed since the pandemic, before, in terms of telehealth usage. And again, I want to reach out to again a good friend and colleague, Rich Bakalar. Rich, from an industry perspective, what's changed for you before and now in the middle of this pandemic? Over.
Well, thank you. Thank you, Ron, for inviting us to participate. Yeah, in terms of before the COVID, I think the key was many of the initiatives were use case specific, departmentally focused. Very few organizations had a enterprise approach to telehealth, and that actually impacted their ability to scale very rapidly once the pandemic appeared. Prior to the pandemic, we had specific use cases that were fairly conventional in terms of neurology, stroke, behavioral health as primary use cases, because those were well represented in the industry as well as well reimbursed. Once the pandemic hit, a lot of organizations really had challenges. They had challenges with the fact that they lost a lot of staff. A lot of hospitals and health systems furloughed a lot of their providers, and so therefore the manpower to deliver health was limited. The other was the fact that they didn't have the infrastructure in place to work across departments, and so oftentimes they tried to insert video into their electronic health record and tried to implement telehealth that way, but that became an issue because of lack of training and experience, both on the provider side as well as the patient side for that matter. And so a lot of organizations actually regressed to telephone services for telehealth, and they were getting reimbursed for that equally, and so they used telehealth through telephone audio only, which surely limited their ability to achieve their goals. A lot of the organizations transitioned from specialty-specific telehealth to urgent care. Clinics were closed, emergency departments were limited in terms of their acceptance of patients because of the concerns over infections, and patients were frankly afraid to go to emergency departments. And so one of our early transitions was to provide urgent care online, where patients could register online and be seen online, both on an on-demand as well as a scheduled basis. Subsequent to that, we learned that the real interest was in population health, trying to manage patients where they were at home, and the ability to be able to not only see the patients by collaboration video, but also to be able to track them and prioritize them for follow-up so that they didn't slip through the cracks. And so we saw a lot, for example, in New York, there was a lot of patients who died at home because they were afraid to be seen in the emergency department or elsewhere. And so the ability to monitor and track and prioritize patients' utilization of resources is a very important aspect, and telehealth platforms can do that very nicely. And then finally, the ability to integrate into the electronic health record is the next wave of integration so that they can get reimbursed, because if you can't get the transaction into the electronic health record, that's typically the means of getting reimbursed for claims. And so the ability to integrate both medical imaging as well as documentation is real important. And that's where we see the focus right now, is how to do this more of an enterprise basis as opposed to a departmental or use case basis.
Yeah, thanks so much, Rich. Those are all really important points. I mean, the staff decrements because of COVID, the cross-department use in EHR integration challenges, training, and then the ramping up of urgent care. You really touched upon a lot of critical issues. I want to reach out to my battle buddy, Joe Woods, online. And Joe, I know you're down at Fort Gordon and you're seeing patients, and you're even an active telehealth enthusiast over the years. I want to bring you into the discussion with our colleagues here and get your thoughts on what we've heard so far. Over.
Thank you. Great to be here, everyone. Good to see old friends. I actually left the Army back in September, so it's been a little while, but I still do some volunteering with the Red Cross and do some teleendocrinology consults from time to time as a Red Cross volunteer. Yeah, had a great discussion. Some of the things I'm interested, since I've not been that heavily engaged with Army medicine for a little while, from both Fran and Sean, is is how this pandemic kind of forced the adoption, because as Sean said earlier, I in my role as the chief medical officer for virtual health, it's like pulling teeth sometimes to get colleagues to try to do telemedicine. And so I'm wondering, how that adoption and incentivization of providers and support staff to do telemedicine, because it had to shift because clinics weren't seeing people in person. So I'm curious what strategies you guys used to help increase adoption, because with any new technology, when you insert it into practice, there's those folks that are early adopters and innovators that embrace it, and then everybody else, it's a bit of a challenge. Over.
Yeah, anyone want to jump in and tackle Joe's question?
Yeah, Ron, I mentioned from the private sector's perspective, one of the things we really see is an interest in trying to make workflows as seamless for physicians and other clinicians, for that matter, as possible. So it's integrating telehealth platforms into the electronic health record has been a critical satisfying activity from the provider's perspective, for their efficiency from a scheduling perspective as well as a delivery perspective. And then from a patient, the patients want to, they don't have to be encouraged very hard. I can tell you from my personal experience, I've actually been a patient in our health system here in Colorado, and I've had 2 or 3 telehealth engagements with my physician, and I can tell you the efficiency that I gained in not having to drive 20, 30 minutes, try to find parking, and not take the medical risk of being exposed. So patients, I think, have well received it as long as there's technology and it's well designed and well implemented. The providers, I think, are starting to embrace it as long as it can be integrated into their workflows and they're getting compensated. And of course, now much of the reimbursement is favorable for telehealth, at least on an emergency basis, and hopefully the payers will learn the value and the quality and the efficiency that's gained by using telehealth. But it really does require customized workflows that work into the general workflow of the providers. We're also seeing professional services organizations working online. So for those organizations that aren't ready, they can contract out for third-party providers to use telehealth and offload some of those responsibilities until they can train their staff and get the integration into their electronic health records. So that's another option we've seen quite a bit.
So
Yeah,
one
I
other
see.
thought.
We'll get to Kevin and then Fran. Please, Kevin.
Yeah, sorry, might have a little bit of lag on the audio. As Rich alluded to, one of the big gains here is that we're getting this into the billing data. We're getting this into the provider billing side and into the actual billing reimbursement side. And what that's also resulting in is we've had this sort of desert of data related to telehealth. So the data are increasing exponentially, and I think it's raising some eyebrows around the nation, certainly. And the CMS restrictions that were lifted and are now probably going to be, if not permanent, much more relaxed regarding telehealth. So we're able to suss out now how many of a particular type of encounter was done via telehealth. And that is a huge, I think, forward leap for us to get increased funding and to get the awareness of senior leadership. Here at Covenant, we already had that, but I know many places are struggling to get senior leadership to recognize that this is not just a temporary blip. The data will show that it is a revenue generator. Over.
Yeah, no, I appreciate that. Fran, we're going to come to you to follow up with Kevin's comments, but we've seen the same thing, Kevin, here at the University of Pittsburgh and the University of Pittsburgh Medical Center. You know, because it got into billing, we're able to see 40 to 60% of our patients are being covered with telemedicine during that, you know, the May-June timeframe with the COVID outbreak. So it really has been a big deal. Billing was always a big challenge as a barrier to telemedicine pre-COVID, and it's really good to see, as you said, billing now being integrated with telemedicine to the extent that we have data. Fran, you want to follow up with Kevin's comments as well?
Yeah, I want to address Joe's comment. Joe, you hit the nail on the head about DOD and the adoption of telehealth, the challenges we've had over the many years. But let me paint the picture. We're down when COVID hit 50% of all encounters compared to a year ago. 50% reduction in encounters. And 40% of those encounters are readiness related, which is a big concern for the military, that our soldiers, sailors, airmen, Marines are ready to go. Then we had some doctors test positive for COVID, so they couldn't come to work, let alone patients not, wanting to come or can't come because face-to-face appointments were at a standstill. Then what happened was, out of necessity, not being able to see the amount of patients we were seeing before, not even close to it, realizing that these numbers are accumulating day by day by day. So as Sean said earlier, and Sean can talk about all the wonderful things that the Virtual Medical Center put in place with Adobe licenses, training, and reaching out not only to the fixed facilities, but the deployed environments, that helped get the message across. I think Kevin mentioned senior leaders, and that's always a key, the culture which you're in. And in the military, that senior leadership guidance is important. No mandates, but information out there, opening up things like Duo, Skype, and FaceTime, expanding those administrative virtual platforms such as Adobe from 500 to 5,000, And then once you get a taste of it, whether you're a patient or a provider, you see the convenience of it. You see the continuity of care. We're not having people, as Rich mentioned, driving far distances, and in the military losing that duty time or training time. So the plus is now the commanders are start saying, hey, and Sean can talk about the wonderful readiness clinics they've established. So our medics can do sick call at their locations, and also in the connected corpsmen in the Navy. And so it becomes a way of practicing. Our challenges remain with the providers and the coding. We see flaws in our coding, and it more so important, I think, in the civilian world when it comes to reimbursement. So we have had education of how to properly code and all. So, Joe, I hope I answered your question about what spurred the telehealth revolution. That I think that, and to the credit of DHA, they put things in place. They communicated. They encouraged initial and follow-up appointments to be via virtual health, and they set policies. These things you can do, these things you can't do. Really helped us roll out virtual health. We're not there yet, but we're on the march. Thank you.
Thanks, Fran. Yeah, the coding always has been and always will be a challenge if it's not integrated into the EMR system to just be part of it. I know there are workflow modules and various EMRs that if it's booked as a virtual health appointment, all those specific codes that identify it as such are automatically put into the encounter. However, with our legacy systems within the military, when I left, we still weren't on Cerner yet at Eisenhower, but with the old Alta system, you had to, as a provider, manually go in and add all the specific codes to designate it specifically as a telehealth. So any of those things, that can reduce coding errors and putting that burden on the providers, I think will also help to improve adoption. I did an analysis of my own practice. I'm an endocrinologist, and I've been practicing telemedicine for over 6 years. I did a program review of my own clinic and compared my workload, my RVU production, compared to all the military endocrinologists across the entire DoD. I did that last year, a couple years ago, and was able to demonstrate, that my RVU production was equivalent to all of my endocrine colleagues across the entire DoD. So that's one of the things that I often heard from my colleagues. They were concerned if they did telemedicine, that their workload productivity would plummet, and that their bosses would be on their backs to, be more productive. But that's one of the things that I specifically looked at to try to spread the word and encourage my colleagues to participate in telemedicine. The other thing I was wondering is, it may be more apropos for Sean, but I'm curious with the limited specialty providers and how cross-regional telemedicine might have ramped up within the military health system. I know when I was very active, I followed some of my patients around the globe, even to deployed environments and in different states as they move. That's one of the big benefits of military medicine with our portable license and things and the global EMR. So I was curious during the pandemic how maybe the virtual medical center was able to cross-level providers across the enterprise. Over.
Sean, did you want to take that?
If Sean's not available, I have a comment from the Navy's experience from the past, if you have it for a moment. But
Sure.
Yeah, go ahead, Rich.
One of the things I was going to mention back in 1995, 96 timeframe, which seems like ancient history in telehealth world, but one of the things we learned is we call reverse telemedicine, where we had doctor specialists on ships from Walter Reed, neurosurgeons, where we could send the patients both data, X-rays, CT scans, and so forth to the ship, and they could follow their patients when they were deployed, because a lot of times they didn't have a full work schedule on the ship, and the patients didn't have a neurosurgeon in Washington available because he was deployed. The other, we would also send radiologists to Guantanamo Bay, for example, and we would send the data from Bethesda, which was his prior workload, to him. And so we would basically do the workload leveling that way, as long as the infrastructure was in place and the governance is in place, that's certainly feasible, and it was actually very effective in those days.
Interesting. Yeah, that's actually how I got into telemedicine. Gosh, I was mobilized to go support WTU. That was in, gosh, 2013 maybe, or 11, I forget. And Kevin Orr, helped me out and his colleagues, and I did the training for telemedicine. So I was in a far away, but I was still able to see my endocrine patients back at Eisenhower as a deployed provider. So that's how I got into telemedicine, and thanks to Kevin, and we've had a long working relationship since.
I wonder if is Sean online to comment?
Yes, I'm on it. I got locked out. I had to dial back in for a little bit. So when talking about all these different things with the military, it's been complicated trying to get specialties involved. I mean, Kevin knows this, and Joe knows this, and Fran knows this. I mean, it's the coalition of the willing getting people involved. And so what we're trying to shift to is trying to mandate some time dedicated to virtual health. And specialists are a little bit concerned about this. But the idea is that we would require maybe 1 or 2 appointments per week, just outside of your area of where you're regularly privileged, so that we can expand this to the nation. That is really a gap that we have, getting specialists involved. And once we have a good platform for everyone to use, we're going to be able to, I think, more easily move this forward and keep this a regular part of our practice. We had a lot of benefits in comparison to the civilian world prior to COVID. We already had some centralized privileging in place. We already had the legal coverage to reach across state borders and international borders to take care of federal beneficiaries. And we need to continue to leverage those great programs and things that we have in place to be ready for the next pandemic. I think we'll have the ability to do that. Over.
One thing, if I may, just to follow up, Kevin, I'll get to you in just one moment here, but what we've seen again in the civilian academic world is that we had sort of a medium level usage of telemedicine. So the platform was in place, but there wasn't this sense of urgency. And then when the pandemic hit, Fran commented on how 50% reduction in telemed consults in the DoD or the Army, but we saw 40 to 60% increase in use because we still had to see our patients. And having that platform in place, the proverbial train as you fight, we had that platform in place, and it was extremely critical to maintaining that academic capability and clinical capability for our patients. So it's ironic that the DoD went down, but in civilian world, I think it went up considerably, especially since they were reimbursing and there wasn't any, you took away some of these barriers. Again, reimbursement and the like all went away, and then it just blossomed in the civilian sector. Fran, did you have a comment then, Kevin?
Yeah, Ron, that 50% reduction was in overall face-to-face encounters, Telemedicine went from pre-COVID at 13%, peaked in April to 50%, and now it's at 30%. So we saw an increase in telehealth. And telehealth, let's be frank here, a majority of that is by telcons in DoD and followed by telcons and some video, whether it be Face, Skype, and then the administrative platforms. So we saw an increase in virtual health, but a decrease initially in the overall encounters across the board. Ironically, Dr. Hipp and I were on a panel the other day with Dr. Galpin from the VA, and they continue to see an increase in virtual health usage, a significant increase, but they're doing many innovative things like giving veterans who don't have connectivity a tablet, connecting with a social worker. It was just phenomenal, all the things that the VA is doing. But again, I think once we do get a clinical platform for the DoD, we'll see it increase from where we're at today with virtual health.
No, I appreciate that clarification, Fran. And again, so you saw a bump up in usage just like we did in the civilian sector. And again, I did a VA telerehab consult recently for some post-op surgical care I needed. And it was extremely well done, very efficient. and it really wasn't a glitch in setting it up for me, with some easy clicks from an email message I got. We want to get back to that VA because, again, the topic of this cool conference is COVID-19 Veterans Health Summit. So the more we can bring in the VA and the veteran community, in addition to the active component, I think would be good. But let's get to Kevin. He's been very patient with some comments. I want to, Kevin, get your follow-up comments over.
Thank you. Now I'm just thrilled to hear this conversation again. So Rich brought something up about what we started to do with reaching out to the field, and I met you, Ron, when we were doing the SMART teams back in 1998, I believe it was, and actually took the first one down to El Salvador, if you remember, for the then Southeast region. So why I bring that up is in Tennessee, where I'm at, we have a 23 county area, very mountainous, very weather dependent sometimes on people being able to reach care, and also the challenges with technology in some of these areas. So as we look towards the future, the things that are being done by Sean Hipp and his folks there with tailgate medicine, connected corpsmen in the Navy, the mobile medic program, those actually have a direct correlation to rural healthcare, the small clinics out there that we can do clinic setups with tailgate medicine, as we called it in the military, the veteran outreaches, sustaining care and preventive care for folks across the spectrum. So I just wanted to kind of encourage maybe a follow-on discussion at some point. That those things are not exclusive. Deployability and readiness are the same technologies and the same procedural basis as what we use in rural healthcare in mountainous areas and in this area, for example. So thank you for that time to comment.
Yeah, no, that's good follow-up, Kevin. Thank you. Rich, I see you got your hand up. Do you want to follow up?
Yeah, just real quick, a couple of other lessons learned is that oftentimes, one of the challenges you have when you have a big surge in performance or adoption is the lack of training for the users, providers particularly. And so one of the things we did early on is the use of both grand rounds and tumor boards and other services in addition to direct encounters, patient encounters. That helps people get familiar with the technology. It helps people get comfortable with the technology and have confidence that it's going to provide either equivalent or better. Another factor is we're seeing, particularly in the private sector, problems with language barriers and even hard of hearing. And so we're using language interpreters built into the system so that you can very rapidly integrate that or bring family members in too. So it's not just an equivalency of care, but it can actually be an enhancement of what you do in a face-to-face world, or you can bring another specialist for that matter to be able to provide more timely care for patients who have more complex conditions.
No, good point. So the training piece is really important. And I see more and more groups looking for some kind of turnkey telemed training solution. It's ironic that, I worked the NATO telemedicine community for 12 years, from 2000 to 2012. I chaired that NATO working group to look, especially with the coalition forces in Iraq and Afghanistan. And I just received an email today, and for our listeners and our panel members here, asking for volunteers with any pre-established curriculum to develop an international telehealth course. So for those of you on this call, especially my colleagues on this panel, if you have content that could go into a telemedicine course that you would be willing to share with the NATO telemedicine working group, I know they would be really interested in that. I've got some ideas and folks where I know they've got those programs in play. University of Virginia and others have them. But if you've got telemedicine curriculum developed and would be willing to share, please reach out to me after this call and I'll connect you with the NATO group. I wanted to just, again, get back to the whole issue of when the pandemic ends, do you see the telemedicine usage sustained, or do you see it sort of going back to pre-COVID levels? What thoughts on that, folks? Yeah, Fran.
Hey, Ron, I really think right now we're at 30% versus 13%. I think we're going to hold that, and I think that there's a couple positive things that will even increase that further. Again, acquiring that clinical healthcare platform, but more importantly, as they roll out that new platform, it's going to have similar capabilities as the VA's current platform. That's a big plus. As you know, the folks on this line, the VA has recently made the decision to buy the same electronic health record that the DoD currently is rolling out. And the plan now with this new DoD virtual platform, clinical platform, is to integrate it into the Genesis, the electronic health record. So those are things that may not happen tomorrow, but by having the same electronic health record, by having the same capabilities, very light capabilities of the VA, which has usually been successful, I'm guardedly optimistic that we're going to see an increase. It will never be, all, 75, 80%, but I'm hoping that we see 40 to 50% post-COVID pandemic.
Great. Yeah, Kevin.
So a couple of thoughts. I believe that although we will see people returning to physical clinics as they feel they're safer to return to or more convenient to their, their normal pattern before the pandemic, we may see a decline in certain numbers in those localities. But I think we're going to see a very rapid and sustained expansion across more services, more specialties, more locations and clinics, more practices coming on board. So I believe that the overall utilization is going to go up dramatically, even though in localized specialty cases, it may have a little dip or decline and sustain a little lower than the pandemic peak. I think telemedicine is just going to be the new normal that everybody is now expecting. We saw that with younger service members coming back from deployed environments and being not really outraged, but a little like shocked that, what do you mean telemedicine is not available at my particular MTF or location? And so to Fran's point, as we integrate the systems and as we start increasing what Sean was mentioning about, removing the barriers, the credentialing issues, the coding issues, all those things becoming standardized across DoD and VA. Now we've got that longitudinal. We've talked about longitudinal record from, recruitment to retirement and beyond. Telehealth is going to be a component in all of that.
Yeah, I don't see us putting this genie back in the bottle after the pandemic's over. I think, and I keep seeing all these different businesses expanding and looking to stand up different networks of care, if you will. So I agree with you, Kevin. I think it's going to continue. But if someone could just clarify, 2 weeks ago, I saw CMS made a decision not to continue payment remuneration for telemed consults. There's no decision yet what happens after the pandemic is supposedly resolved. Have you all heard anything more from CMS on whether they're going to continue to compensate for reimbursement after the pandemic over? No, I wasn't sure if you all are tracking that. Rich, you had your hand up earlier. You have a follow-on comment you want to make?
Yeah, I was going to say, I think the big difference post-pandemic, I call PC, post-COVID, I think is going to be the fact that organizations are going to recognize that we can't do this on a use case by use case basis. We need to have more of a platform, modular platform approach to doing this so that the first or second implementation may have a heavy lift, but the incremental adding on new services and new delivery models and so forth can be very easily added on. The other thing is that we have to recognize not only do we have to code for telehealth, but we have to document so that reimbursement isn't considered fraud when you don't have adequate documentation. So the minimal requirements for documentation are going to be critical going forward at scale. And then thirdly, we have to look at our data warehouses and making sure that we're incorporating telehealth into those data warehouses adequately, because if it becomes a higher percentage of the total productivity of the organization, that has to be well represented, and you have to have the accountability just like you do for the rest of your face-to-face care. So I think there's going to be governance changes, there's going to be infrastructure changes, and there's going to be regulatory changes that are all going to be critical in making sure that we don't lose the momentum we've achieved during the pandemic. But I think, like you said, he's out of the bottle, and we're going to, it's going to happen. It's just a question of what rate and how fast.
Yeah, Rich, you represent industry on this panel, as well as clinical and your longstanding work with Navy Telemed. But from an industry perspective, wearing that hat, do you see the future of telemedicine as a, industry friendly and a growth area?
Well, I think if you look at what was announced yesterday, I guess American Well, it's going IPO with $100 million investment by Google. In Touch was acquired by Teladoc. We're seeing a lot of mergers. We're seeing a lot of investment. I guess the markets are seeing opportunity in going forward. So I think from an industry perspective, there's no question there's going to be winners and losers going forward. But I think the growth of this industry is essential, but also inevitable. It's just a question of who's going to survive and who's going to have to adapt to be able to survive.
Yeah, no, thank you for that. Yeah, Joe.
Yeah, I was curious if any of you in your healthcare systems have gotten a pulse of what the patients think of telemedicine. I know when I was very active in my own telemedicine practice, I surveyed all my patients, and the satisfaction was consistently over 95%. That was for an endocrine practice. So I think that our patients are going to drive a lot of the need to opt and ramp this up and make it easier. I'm curious, have any of you in your systems collected any data yet on patient satisfaction?
Hey, Joe.
Hey, I'm sorry, go ahead, Sean.
Yeah, Fran.
Yeah, I know, Joe, Fran was trying to comment on the same thing. We've collected a lot of data. Just on our readiness clinic, Viper Clinic is over 98% satisfaction from the people that participate in that. And then we've done over 30,000 telemedicine appointments with our readiness clinic. But the same is happening with the other areas. We can't say the exact same satisfaction from the provider side, because again, I've talked about the platform off and on. But that's truly, I think you can say the patient is going to drive this. We've changed in the military with, we've had to use platforms like Microsoft Teams to telework, and people want to continue teleworking. We've actually found that as we shifted to home, our productivity from our, not just clinicians, but our staff in general has improved. So I think clinicians as well as other administrators are going to drive this continued telework, which is going to mean we're going to have to continue to do telemedicine. So I think patient and provider are going to continue to drive these forward, and the military, certainly once we get a better platform, are going to just kill it on this. Go ahead, Fran, I'm sorry.
No, Sean, you said it well. And an interesting statistic, a recent survey, they asked providers what percentage of your patients' needs do you think you could fulfill with virtual video or with virtual health. 19% said 11 to 30% of patients, 25% said 31 to 50%, and 21% said 51 to 70%, and about 4% said greater than 71%. I dare say if these numbers were collected pre-COVID, they'd be much less. We've rolled it out there. The patients love it. Satisfaction has been just as good, if not better, than a face-to-face. And we know that there are some face-to-face required types of appointments. We can't get away from that. But I think now that they have a taste of this, both providers and patients, we're going to see it continue to increase.
And I wanted to encourage our audience. I know we've got several attendees on this webinar. If you have questions, please use the chat feature. We have several minutes yet to answer questions for this distinguished panel, so certainly encourage you to do so. Let me see where else we can go here.
Ron, I passed a couple to Joe. Joe, did you get those questions that I passed from the audience from the question function, which is separate here than the chat function?
Yes. I wonder if I could get some feedback first, if you don't mind, from Kevin and Richard about patient feedback that you might have seen within your respective organizations. Over.
So I'll be short in my response. It's been overwhelmingly positive. There have been, for example, that I asked the behavioral health folks how it was being received by providers and by patients for the groups that we reinstituted. And the words that they were using were words like ecstatic, wonderful, superb. I mean, it was over the top. And so it wasn't that they were changing the content or anything they were doing. They were changing the convenience and the access. And so now people who maybe had social stigmas that would have prevented them from coming into a group environment could participate in a group environment without those stigmas, nullifying their involvement. And so I think that's just one anecdotal case, but the providers were seeing more engagement and actually more control and timeliness for the group interactions. Over.
Thank you. And my experience is very similar. The only thing I would add is that it's real important to consider the trust. The trust factor between providers and patients is extremely important. And so if you're seeing your existing provider, whether it's a specialist or primary care, I think there's very little resistance to using this technology or this mode of delivery. I think where it becomes more of an issue is if you don't know the provider, or it's a provider that you don't necessarily know or trust, that potentially could be an issue for the patients. And then of course the privacy concerns. My wife's a psychiatrist. She's been practicing telehealth for 30 some odd years since she was in active duty. And one of the lessons learned is sometimes video is not necessarily the preferred mode, particularly for an analyst. You want to have similar to what you do in a real world, which is a couch and you don't look at the patient. So in her case, audio is actually preferred. So I think it's how we use the technology and who the providers are for the individual encounters will determine the receptivity by the patients and the confidence in the patients of using it.
Thank you. I think I'll go ahead and jump into some of these questions, Ron, if that's okay with you.
Yeah, please fire away, Joe.
From the audience. Yeah, so I'll just read this verbatim. Even pre-COVID-19, suicide was even more prevalent among physicians than combat vets. Healthcare is, I believe, one of the top 5 most hazardous workplaces. Peer support groups need to be expanded for all people, but especially now. Have you considered using the platforms for peer-supported groups for your own medical staff?
Hey, this is Sean Hipp, and that is certainly being set up right now, at least on the Army side. And I know Fran can comment on this, but we're looking at our personnel that are coming back from these COVID missions and these local support, where they're seeing critically ill people having to make critical decisions, and that's a significant stress upon them. So we're trying to build some of our behavioral health support so we can have peer-to-peer support, and this is a key component for virtual health to come in. So at least we're going to set up a phone line and potential video in order to do that support during this pandemic. Over.
Great, thank you. Fran, did you want to comment as well?
In part of the coming back into the fold, I know that Sean again has set up these readiness virtual clinics, and we're considering that for the post-deployment coming back into the fold is a specific example of that, which is just a wonderful opportunity. It's convenient, and we're reaching out to all the folks who have been at these hot spots fully engaged.
Thank you. Next question from the audience regarding specialists taking vital signs, manipulating joints, examining wounds. Many services can't be provided in a distance fashion. Are there some routine patients to whom you might consider pulse oximeters, blood pressure meters, etc.? I can answer some of that. As an endocrinologist, I had a number of my diabetic patients utilize remote home monitoring equipment, so I could monitor their weight, their blood pressure, their finger sticks, and exercise using a Fitbit remotely, and have all that data come in that could then be put into the electronic medical record. Then I would review that, and then I could make medical decisions and communicate that back asynchronously to the patient. If my plan needed to be more complex and could be communicated through asynchronous means, secure messaging, then I would do a direct-to-home video visit for those diabetic patients. And I can tell you that I had a number of those patients that I saw for a whole year. I never needed to have them come in. They came in to get their retinal exams and lab work and things like that, but I managed their diabetes, and their outcomes were just as good as seeing them in person. That was a fairly small number, But we also did the same type of thing in a nephrology clinic for their hypertension patients and a cardiology clinic managing CHF patients. And the patients overwhelmingly liked it. One of the other things I would say in regard to that question, if you are doing telehealth, say from a medical center to a smaller clinic, then on that patient side, if they're in a clinic, you can have a presenter do a lot of the things perhaps for you for some of the things if they're adequately trained. But when they're at home, then that becomes a bigger issue. I know I was fortunate to work with great staff at some of the military clinics that I provided consultations and worked with those nurses and staff. We would do remote rounds. The nurses would follow up with the patients. We had a great clinic. I tried to replicate in many ways what I would do in person with case management, case coordination, et cetera. And I'll open it up for any of the other panelists to comment on that specific question. Thank you.
And Joe, I would just add to what you said, I think the key is to be able to have a hybrid environment where you can use telehealth when appropriate and you can use face-to-face when appropriate. So for example, pre-op evaluations, you may or may not need to do a physical examination of the patient. If not, then telehealth would make a lot of sense. For those patients, you have to do oral exam or other things, you know, you may want to bring them in. So I think having an integrated platform into your electronic health record allows you to have that, you know, audible decision of what you want to use telehealth or, and some of that may be determined by the provider and some of that may be by the patient as we go forward. And so I think that ability to integrate, I think it's going to be really important as we go forward.
Kevin,
go
I'm
ahead.
sorry, just Joe, maybe we got time for maybe just another minute or so. I know Kevin's got his hand up as well. So Joe, if you want to finish up and then let Kevin comment, then we'll probably have to wrap this session up. Over.
I was just going to say, because there was a question about wounds, we actually had our surgeons do about a year-long project where they followed up with fairly simple operative procedures, lap choles and hernia repairs. They would follow those patients up via video, home video, and the patients and the docs felt that they could do an adequate exam by examining the wound over video. And I'll stop there. Go ahead, Kevin.
Short response to what Rich said, that, you know, it's a decision between the patient and the provider as to what is appropriate for them in that order, I believe. And then the continuity of care factor in this. So being able to treat them at home or locally in a clinic with telemedicine plus days of travel, you know, that's pretty obvious benefit, but it's real. And I'll end there. Thank you.
Well, again, I just wanted to thank everybody for participating in this session. I mean, we've all been friends and colleagues over the years, Fran, Kevin, Sean, Rich, and Joe, and it's really a treat to see you all and to hear your comments on telemedicine. As bad as this pandemic has been, you know, I find that I don't shave as much and my dry cleaning bill is a lot less. So there are some small glimmers of benefit, I suppose, to the pandemic. But the biggest benefit is really just reconnecting with you all. And again, our thanks to Consensus Health and to Sean Mannion and all the folks at Consensus Health for allowing us to spend this last hour talking. So we're going to pivot to the next session that Dr. Joe Wood will be moderating on innovations in telehealth. So in the meantime, I again thank you all for turning in and turning on. And here's Sean Mannion.